is a relatively new area. We'll try to understand the role of anti-HBs titers in functional cure of HBeAg positive chronic hepatitis B patients. So we'll be more understanding the title of the talk at the end of the presentation, and I'll start with the question. We do anti-HCV for screening hepatitis C patients, but we don't do anti-HBs for screening the patients of hepatitis B. So why do we not do anti-HBs for screening the patients of infection? Because hepatitis B has a special survival advantage with many subviral particles without the HBV viral DNA produced in the serum by the hepatitis B multiplication, incomplete virions, subviral particles. They are more than 10,000 times the actual virions per se. So these subviral particles, they decrease the neutralizing effect of the anti-HBs on the HBV DNA virions, HBa whole virions, and render the humoral immune response ineffective in controlling the infection, because they saturate the immunoglobulins with the HBs subviral particles. These immune complexes of HBsAg and the anti-HBs, which are ineffective in anti-HBs, is difficult to measure in the labs, and few methods have been identified and described since last 20 years, but not routinely practiced in the regular practice. And additionally, it has also been shown that as the titer of the subviral particles increases, the neutralizing effect of the anti-HBs goes down and the virus multiplies more. So it is difficult to detect host antibody response in hepatitis B surface antigen positive patients. So humoral immunity is difficult to assess. Additionally, the anti-HBs binding domain, this is the A determinant, this is the HBsAg pictorial representation. And this HBsAg has at least 19 epitopes. Epitopes is the most immunologically active parts of the antigen. So at least 19 epitopes have been identified on the HBsAg antigen, and the most common site where the anti-HBs binds is the A determinant, which is from 124 to 148 with loop 1, loop 2. So on this HBsAg antigen is a conformationally dynamic protein, and its tertiary structure determines its antigenicity. And the anti-HBs may recognize these epitope clusters. It may not, every anti-HBs may not recognize all the 19 epitopes, and the number of epitopes recognized will determine its effect. I'll come to that later. So first we'll try to understand what is functional cure in HBV infection. So HBV DNA not detected with surface antigen loss, with or without the anti-HBs status presentation. This is functional cure, and this is the goal of treating any hepatitis B positive patients, because once it is achieved, we may be able to stop the treatment, we may decrease the progression of fibrosis, cirrhosis, HCC, and improve the survival. But this is rarely achieved. Only 1 to 2% of the patients of chronic hepatitis B develop this functional cure. And as Ankur rightly said, the ALT flares and functional cure are closely related. There are good flares. Good flares lead to reduction in HBV DNA, EAG seroconversion, and functional cure. And this is mostly mediated by cytotoxic lymphocyte cytolysis of the infected hepatocytes. And coming to the B cell response in functional cure, this is not much studied, not much data. Only little recent literature is coming up, which I'll be discussing in further slides. The B cell clones encoding the anti-HBs with low affinity to many of the epitopes of the homologous HBsAg exist in most patients with chronic hepatitis B, but difficult to detect because they exist in complexes. The anti-HBs response is thus both quantitatively and qualitatively inadequate or inefficient to clear the virus. But anti-HBs production is not completely blocked. So, and additionally, in acute hepatitis B, it is known that the coordinated interaction of the HBV specific T and B cells is required to achieve the clearance of the virus. Such a concept is not studied in chronic hepatitis B for functional cure. Additionally, HBsAg is vulnerable to changes in the structural alterations or alterations in the epitope availability with the duration of the course of the illness and as well as the treatment. And epitope availability and epitope occupancy, these are the terms which I will discuss in further slides. This will decide the clearance of the anti-HBs response by the patients. So what are these epitope profiles? Epitope occupancy, epitope mapping. So recently some tests have been, Roche has come up with some multiplex, 19-plex epitope mapping assay to targeting these anti-HBs epitopes across 5 major HBsAg domains. Epitope assay displays the antigen conformation and occupancy influence of HBsAg profile. It tells us how many epitopes are occupied or how many are available by the interaction between the HBsAg and the anti-HBs. So this is the test which I will discuss shortly. This is the 19 monoclonal antibodies are available for each of the epitope. They are fluorescent, and depending on the interaction, the fluorescent color comes, by which they can identify the folds by which the particular epitope is available or lost. So a few more terms in epitope binding. Number of HBsAg epitopes bound. It is the total number of occupied out of these 19 possible HBsAg. This tells us the breadth of the anti-HBs response, on how many epitopes the anti-HBs is acting. And the next term is binding value. Binding value is the occupancy of the epitopes relative to the standard HBsAg reference. Like how many epitopes are occupied by the anti-HBs. A low binding value means the epitope is unavailable and the innate the host antibodies are holding on to the epitopes, and thus it is an indirect measure of specificity of the anti-HBs response on the HBsAg. So this can be complete. Most of the epitopes may be blocked. In that case, the binding value will be the lower the binding value, the higher is the anti-HBs specific response to the HBsAg. I hope I am clear. The binding value is the free epitopes on the HBsAg which are available for further binding. Okay, so predicting the HBsAg clearance in chronic hepatitis B using HBsAg epitope profiling. Only this is a very niche group of patient profile, like many thousands of patients who were followed on nukes in E positive patients who achieved functional cure. Only 14 patients achieved functional cure, and the samples of these patients are studied in multiple studies for this profiling of the epitopes. So this is how the profiling looks. The profile is, the lower the binding value, that means the epitopes are occupied, and it is represented as the folds of change compared to the standard HBsAg epitope profiling. So in the patients who have achieved functional cure, the epitope binding will be lower compared to those who do not achieve epitope the functional cure. And it was shown that by the end of 48 weeks or the end of study, 11 out of the 14 patients who achieved surface loss had this epitope profile, and which started to appear at 48 weeks. And only 1 out of the functional cure patient achieved this epitope profile. So HBsAg epitope profiling can be a biomarker for functional cure, and it can predict the future development of functional cure in patients with chronic hepatitis B. All these patients are from HBeAg positive patients who are started on nukes. So development of an HBsAg clearance profile that coincided with the HBsAg decline or ALT flare. Most of these patients had who achieved this clearance profile had ALT flare. 12 out of the 14 patients had ALT flare followed by this onset of this clinical profile. And the complex anti-HBs and HBsAg complex is also associated with the onset of HBsAg clearing profile and HBsAg response. So increase in the ratio of this anti-HBs complex HBsAg to the free HBsAg is determinant of recovery of the immune response, humoral immune response against the hepatitis B. Okay, and this complex anti-HBs antibody and anti-HBsAg were identifiable in 10 of the 14 patients who achieved functional cure, while only 1 with a high negative predictive value and positive predictive value. So, and it has also been shown that this complex surface antigen anti-HBs complex peaks versus ALT flares And if you can see this diagram, these are the patients who achieved functional cure. This is the complex anti-HBs and HBsAg flare. This is the ALT flare. In those patients who achieved this complex flare followed by ALT flare, they are the ones who achieved functional cure. In the non-cured patients, the complex flare was not followed by ALT flare. So ALT flare is important following the complex flare to sustain a good humoral antibody response and viral clearance. So it is a measure of amount of anti-HBs activity against the HBsAg as well. Coming to next concept, this is FCCR3A. It is a receptor, CD16 receptor present on the natural killer cells. So binding of the anti-HBs over this NK cell receptor and dimerization of this receptor on the NK cells brings out the conformational changes in the FC segment of the anti-HBs titers, which leads to activation of the NK cells, further augmenting the cytotoxic killing of the HBV infected cells. I hope I am making sense. Okay, so this dimerization of this FCR3 is a surrogate marker of antibody dependent cytotoxic cell activity. Okay, so this was also seen that 9 out of the 14 patients who achieved this functional cure had this dimerization, and this dimerization and this dimerization was independent of the HBsAg immune complex or ALT flares. So this is to say that the antibodies can augment the humoral immunity, can augment the cytotoxic cell activity even in patients with chronic hepatitis B who have E positive things. Yeah. And coming to the epitope occupancy and circulating HBsAg. This is a measure of broadness or diversity of the anti-HBs response at each time point. So as the occupancy or the number of epitopes occupied by the anti-HBs in the patients go higher in patients who achieved functional cure, light blue color, by 48 weeks, there was twofold increase in the epitope occupancy in patients who achieved functional cure, while by 12 weeks itself there was threefold decline in the non-FC patients in the number of epitopes occupied by the anti-HBs. So these things can help us in identifying the patients who are going to achieve functional cure in future. And additionally, HBsAg epitope occupancy of this free anti-HBs after the HBsAg loss, like when compared between the efficacy of the anti-HBs titers which are produced in functional cure patients versus those who achieve this anti-HBs titers because of the vaccination. So the quality of the anti-HBs is different between those who achieve anti-HBs status by functional cure vis-a-vis those who achieve this by vaccination. As you can see, the more blue numbers means lesser the occupancy available, and it was shown that number of epitopes which can be occupied by the functional cure patients anti-HBs was much higher compared to those who received the vaccine. So seroconverted functional cure patients generate anti-HBs response that is significantly higher and better with occupying more HBsAg epitopes. And additionally, there is something called neutralization effect of HBV infection by anti-HBs. This is indicated in IC50 levels. IC50 levels. So neutralization effect, 50% decline in the DNA by the at what titer of the anti-HBs. Okay, the IC50 levels were much lesser. The left is the lesser, the dark blue is the FC patients, light blue is the FC patient at a nearer time frame, and the gray colored is the pool vaccine anti-HBs titers. So FC functional cure anti-HBs is more effective than vaccine anti-HBs in achieving the neutralization potency of the hepatitis B antigen. And additionally, you can see there is a decline in the anti-HBs titers over time and decline in the IC50 values in FC patients. That means to say, in the long run, even with a lower anti-HBs titers, the functional cure patients are able to neutralize the virus in a better way than the vaccinated patients, even with the lower, because of their higher epitope occupancy. Okay, coming to the relationship between this neutralization potency, anti-HBs titers, and HBsAg epitope recognition. So, as told earlier, IC50 was lower in functional cure. Anti-HBs status were also lower, despite the anti-HBs status being low in the functional cure patients, and there was significant negative correlation between the IC50 levels and the HBsAg epitope recognition. If the number of epitopes recognized are higher, the IC50 value is lower. Okay. So this is my last couple of summary slides, pictorially representing what all we discussed so far. So this is the representation of functional cure patients. As the viral markers like DNA, HBsAg, HBeAg start to decline, which is succeeded by the ALT flare, and this is preceded long before by the formation of immune complex, like a clinical profile, clearing profile, what we discussed earlier, clearance profile of the epitope HBsAg, which starts at 12 weeks after the start of treatment, nucleosides in EAG positive patients with initial ALT high. Okay, and this immune reactivation and HBsAg clinical profile development is followed by development of anti-HBs and HBsAg complex formations, which superimposes with the duration with the ALT flare, which is followed by HBsAg loss or seroconversion, and seroconversion may be present or not in functional cure, anti-HBs status positive. But in those patients who do not respond or do not develop functional cure, the initial ALT flare is a brief one and inefficient one, and the HBsAg levels do not go down as compared to will remain same HBsAg quantitative, and along with that non-clinical, non-responding, non-clearance profile and no HBsAg decline we discussed. The immune complexes, anti-HBs and HBsAg immune complexes, they appear here and there as purple lines here, but they are transient. And this suggests that there is insufficient or inefficient antibody response to HBsAg in those who do not achieve functional cure in patients with E positive on NUCs. So now we read the title again so that we will understand the content. Role of anti-HBs in achieving functional cure of HBeAg positive chronic hepatitis B. So anti-HBs has a significant role in by itself and also augmenting the cytotoxic cells. Anti-HBs response is an important contributor in both the pathogenesis and resolution of chronic hepatitis B. And functional cure and non-functional cure have different anti-HBs profiles. Anti-HBs profiles may have both diagnostic, prognostic value. B cell responses defective in unresolved chronic hepatitis B, probably necessary for clearance of hepatitis B with antibody-dependent cytotoxic clearance. And we need more data, especially the data whatever is available is only in geno A. We need data in other genotypes, and we may also look into the data in HBe negative patients and all the clinical profiles about this epitope profiling, mapping, binding and everything. And this is a relatively newer area, and maybe we should do more work here, and I hope I could make some sense.